Hey everyone. So in this video, we're going to talk through a low back pain case scenario, and we're going to briefly discuss the subjective and the objective information that we used to develop a thought process behind the intervention that we're going to talk through. Okay, the intervention has more of a coordinated focus to essentially build greater low capacity through the distal quadriceps while simultaneously reducing the extension demand on the lumbar extensors. So we're building quads here for this client's low back pain. Okay, but not for 1 minute are we saying that the client's low back pain experience was caused by weak quads. We're not saying that at all. We're saying that there was an inability of the distal quadriceps to manage and generate forces. And this was gathered from both the subjective and the objective information. So what we wanted to try and do is restore some variability from a muscular standpoint by concentrating more load through the distal quadriceps via knee extension and tibial extension, and potentially reduce the extension demand on another area. So we wanted to distribute that extension across the lower limb instead of concentrating it at certain areas, because this client did have good range of motion across the spine, the pelvis, the femur, the knee, and the foot and the ankle. So one of the things that we'll talk about here are the two features that are going to guide our thought process in terms of understanding what kind of loading strategy to use. Okay, but let's dig into the case and briefly discuss things. So this client had a current experience of low back pain, which was worse on the right side. And when it became worse, it extended into the posterior lateral hip on the right side. And it was primarily worse after activity. So whenever a client has increased pain after activity, what it does for us is it encourages us to question the load sharing capacity of the lower limb, because the lower limb is ultimately the body region that's in direct contact with the external environment. It has to manage direct forces and distribute those forces from distal to proximal through to the proximal tissues. So some of the things that are some of the questions that are on our radar is, does the lower limb have the capacity to manage and generate those forces? Are we seeing an increased concentration of forces proximally, secondary to poor load capacity, poor load sharing capacity across the lower limb? Okay, doesn't mean that this is what's going on, but it's a question that's on our mind during the subjective assessment. Okay, if this client, think of that, just going back to the worse after activity, think about this relative to a client that experiences more pain after a period of rest, getting up in the morning, for example, getting out of bed, standing up after sitting down for a long period. Sometimes you'll have clients that feel increased tension, increased discomfort and pain after transitioning from rest to movement, but then after movement they feel better. This client felt worse after movement, after activity, specifically running. There was a history of an ACL reconstruction 5 years ago, and the client underwent rehab, progressed back to sport, progressed back to running. Okay, but I'll tell you now, typically when we have a client that has a history of an ACL reconstruction or any kind of knee surgery, very, very often we find that the client continues to express poor load capacity through the quadriceps, particularly the distal quadriceps, which can be highlighted through the behavior of the tibia. Okay, so even though they've done all their squats, their lunges, this client is in the gym doing lots of quadricep-based strategies, loading-based strategies for his team, but still the distal quadriceps are struggling to manage forces in isolation. The distal quadriceps are struggling to concentrate those forces. Okay, so again, one of the things that we need to consider here when we are working with anyone that has a pain experience, of course, we need to consider non-physical stressors, non-physical factors, the fear behind the client's movement behavior, the beliefs about their pain, the confidence in their body's ability to manage forces. All those non-physical stressors need to be appreciated when it comes to dealing with a client that has a pain experience. What we're going to talk about here are more the neuromechanical influences, the physical stress moving through the body, the forces moving through the system, how well the nervous system, the anatomy are interacting to be able to manage and distribute forces. So two things that we talk about here within our courses is this idea of space capacity versus coordination. So from a spatial standpoint, we're looking at range of motion. We're looking at the dissociation capacity between individual segments. Do neighboring joint segments have the capacity to move relative to each other? From a capacity issue, we're looking more so at the muscular behavior, the individual muscular behavior. Does an individual muscle have the capacity to manage and generate forces using different contractile behaviors? So does a muscle have the capacity to manage and generate forces with more of a eccentric behavior, an isometric behavior, and a concentric behavior? Ultimately, that allows it to express variability in its capacity to manage and generate forces. Think about this relative to more of a coordinative issue, where there may be a challenge in distributing forces or sharing forces across a more global body region. Okay, so in this client scenario, there was a capacity issue locally at the quadricep, the distal quadricep, which was, again, this was our hypothesis at the time, that this was potentially influencing the amount of extension demand at the lumbar spine. So we wanted to share that extension capacity across the lower limb. Because one of the things that we noticed in this client from an objective standpoint is that he had full range of motion at the spine, in both directions, in all directions. At the pelvis, at the femur, he worked with another therapist to develop that range of motion, but still experienced pain after activity. So potentially this client had an inability to manage and generate forces appropriately while holding on to that joint segmental variability. Okay, so it was more a case where we needed to influence the behavior of the spine while simultaneously influencing the behavior of the distal quadriceps. So this was, again, just one intervention that we used. So let's talk about the intervention. So what you'll see very often in clients with poor load capacity through the distal quadriceps is an inability to maintain tibial flexion. Okay, when that tibia flexes or maintains a position of flexion, gravity and the mass of the head, trunk, and arms will try to flex that tibia even further. That will increase the challenge on the distal quadriceps to maintain that tibial position. But if the distal quadriceps don't want it, if they don't have the capacity to maintain that tibial position, then what you're going to see is this very quick extension of the tibia, where the tibia is going to become more vertically orientated, where there's more axial load now going through the tibia. So there's not as much challenge on the distal quadriceps. Okay, so what we wanted to do in this position here was pre-position the spine into flexion. So we're reducing the demand of the lumbar extensors. We're trying to express more eccentric behavior through the lumbar extensors by flexing the lumbar spine. We're using ribcage flexion, head flexion to facilitate that, and we have the pelvis bias towards more extension as well to facilitate that lumbar flexion. Okay. What we're then doing is pre-positioning the knee into flexion, the ankle into flexion. And what we want the client to do is to crush down through the heel here as they build pressure down into the ground, but they're projecting the force up and slightly forward. That's why we have the hands on the table here, so we can give space for the head to move through. Because when we're projecting force directly upwards, there's going to be more of a tendency to extend that tibia earlier. Okay, whereas when we project the force up and forwards, it's going to be a little bit easier for the client to maintain that tibial flexion. Okay, so we're not necessarily using the hands to build pressure into the table here. We're just using them for balance here. Okay, so crushing the heel and simultaneously reaching the knee forward so we can keep that tibial flexion. And with that simultaneous crushing of the heel, reaching the knee forward slightly, not to the point where we're lifting the heel off the ground, but if we can maintain that heel contact, what that ultimately does is reduces the ankle extension contribution. So we're not getting any contribution from the plantar flexors here. That really allowed the client to really feel a burn in through the distal quadriceps. And this is something that really had a positive impact on his symptoms. And we loaded it up more. We added more kind of volume to this. We added more coordinated challenges. But this was the first strategy that we used, because this client was struggling to keep that tibial flexion during the assessments that we use for the quadricep. So you're going to see it here. Drive down, lift. At the beginning, we can start with just a small hover of the pelvis from the chair here, but then we can move through a greater range of motion through the femur. So that femur is moving into extension here. We're trying to maintain some tibial flexion. If we can maintain that tibial flexion, then what's going to happen is we're going to be able to concentrate that force through the distal quadriceps. Okay. Now, of course, we're starting in a position of femoral flexion here, so we are going to be loading things like the proximal hamstrings, the adductors, not necessarily just the distal quadriceps. But when we're trying to concentrate load into the distal quadriceps, the key segment that we want to consider is the behavior of the tibia. We want to keep that flexed. It's of course going to begin to extend slightly, but we just want to keep it relatively flexed across the movement task. So we're not trying to extend the knee into a lockout position. We're just trying to change the coordinated strategy used across the lower limb, give that nervous system the experience of concentrating that load through the distal quadriceps while simultaneously reducing the contribution from the lumbar extensors. So ultimately, again, loading the distal quads, like I said, simultaneously reducing the flexion of the pelvis, which would be an anterior tilt, lumbar extension, trying to maintain tibial flexion to concentrate load at the distal quadriceps, crushing the heel into the ground, and simultaneously reaching the knee forward. And again, one of the key things here is projecting the force up and forward, not just directly upwards. Okay, so lots of things to consider here. Again, like I said, it was one intervention as part of this client's overall rehabilitation plan. We used other strategies to reduce the coordinated demand as we concentrated load into the distal quadriceps. But this was a strategy that had more of a coordinated focus where we're trying to increase the extension demand at a certain area and simultaneously reduce that extension contribution from another area.